So I'm delighted to introduce our next speaker, Professor Nizam. He's a leading transplant surgeon, humanitarian, and someone who has been at the heart of reform and seen many planning cycles in the past. And also, I'm very lucky to have him as a colleague at Strasys. So if I can ask you to take over, Nizam, please.
Thank you. Can I have the first slide, please? So, as Naeem said earlier on, the planning process for the 10-year plan didn't include timely publication. So rather than talking about the 10-year plan having been published, I'm going to focus on what it might include when it finally does come out. And I'm reflecting back over around 40 years of clinical practice. So I'd like to start by thinking about whether the service that the patient gets is better now than 40 years ago, because you would certainly hope that it should be. It's certainly true that hospital stay is shorter. We use more evidence-based medicine. We have better training and supervision, and we have better treatment and governance protocols. And one example in the reference there is the dramatic reduction in MRSA rates as a result of hygiene protocols. It's also true that despite the fact that the NHS has a huge number of inefficiencies, its productivity has actually been rising. That's the blue line in the chart, compared with other public sector areas in the yellow line, or the wider economy, which is the grey. There's obvious downtick at the end due to COVID. Next slide, please. However, there are a huge number of inefficiencies. Some of you may have seen this report last week in The Guardian. A quarter of the elective operations which were cancelled at the last minute, so a quarter of the 85,000 operations cancelled at the last minute over a year, took longer than a month to rearrange. That's clearly inefficient. There's a huge variation, in my view, in the quality of care, especially at DGH level, although not exclusively so. We still come across patients who end up spending an extra day in hospital because the paperwork is not ready or the medication is not ready. Despite having spent literally billions of pounds, we don't yet have a universal electronic patient record. And we have very, very high bed occupancy rates, which means that as clinicians, we're often faced with being told you can't admit a patient for urgent treatment or investigation because we don't have any beds. We all know about social care and the effect that that has on the NHS. And we still end up with communication gaps where tests might be delayed and therefore affect later treatment. Next slide, please. So underpinning this variation and inefficiency, I think there are some key areas. Over those 40 years, what I've seen is that patient-facing services have been downgraded. So nurses on the ward have less time to spend with patients. Medical secretaries, for example, people often think of those as simply people who are going to type up letters, but they actually had a much more profound role. And I'll give you an example. Last year I was overseas. I had an appointment with a knee surgeon. I needed to rearrange it. I couldn't get through to the number that I'd been given. 30 or 40 years ago, I'd have just phoned his secretary who would have rearranged it. But I became a DNA, which is clearly inefficient. Innovation has become a really big problem. It's not an exaggeration to say that if you want to do something new, it takes more than a year to get that through the various processes. I can recall some 25 years ago starting a transplant program where we were transplanting people where blood groups didn't match for the first time in the UK. And that involved a conversation with a clinical director and a 10-minute conversation with a medical director, and then off we went. These days it would take over a year, and people often give up. Planning is, in my view, relatively inefficient at hospital level. Hospital services are not planned according to patient need the biggest departments are usually the departments where the consultants are best at writing a business case rather than the ones which actually need more personnel. Next slide, please. And when we think about what we need in terms of workforce, we don't actually know how many doctors we need and what we need them for. So the long-term workforce plan, like many workforce plans that I've seen over the years, is very, very crude. It's based on an assumption that the population is aging and therefore will be sicker, on a policy of shifting care to the community and improving access and performance. But it doesn't really get into any granularity. So, for example, there's no data about how many doctors in a particular specialty are likely to retire over the next 10 years, or what the demand for that particular specialty is likely to be. So, for example, do we need more paediatricians when our population is aging? Do we need more kidney doctors when we have new treatments which are preventing the development of chronic renal failure? Do we need more heart specialists? If you look at this graph, you can see that the admission rates for cardiovascular disease over the last 15 years have actually been falling quite dramatically. So do we need to be increasing or decreasing the number of cardiologists? And it is actually quite difficult to decrease the number of consultants once you've appointed them. Next slide, please. While we're speaking, tens of thousands, if not hundreds of thousands of patients are in outpatient clinics across the country who don't need to be there and don't actually want to be there. The Royal College of Physicians published a document some 7 years ago talking about the use of patient-initiated follow-up, but that's still relatively uncommon. We still bring patients back to clinic far too often. I apologise to those of you who write these documents, but we receive 50-page, 100-page documents from the Trust or the Department of Health. Most of the time, we simply press the delete button. If we do read some of them, it's a very inefficient way of conveying information. Mandatory training as a concept is good, but I can't tell you the number of hours I've spent over the years as a surgeon listening to someone telling me how to wash my hands. And I negotiated the introduction of the appraisal process on the behalf of the British Medical Association many, many years ago. I'm sorry to tell you, I think it's largely a waste of time. I'll come back to theatre utilisation in the next slide, but I've given you 4 examples here. All of these happened, these are real examples, all of them happened within a week of each other. These are very, very common scenarios that we come across. So somebody who gets sent back from a CT scan because the cannula where they need to inject the dye isn't working. That slot is not used for another patient. The patient spends another day in hospital. The efficient thing to do would have been to have somebody in CT scanning who could recite cannulas. Somebody who needs a heart x-ray, having had a heart attack after a transplant, spends an extra week in hospital because the x-ray is done at another hospital and transport and a bed need to be arranged. A 72-year-old woman has a minor procedure, doesn't need to occupy an acute bed, but can't go home because she lives alone. So she needs step-down care within hospital. That's not available, so she ends up, if you like, blocking a bed. And on a Monday morning, the theatre staff discover that 20 staff across the whole theatre complex are absent due to illness. And so what they decide to do is just put all the lists on hold for 2 hours while they have a meeting to decide what to do and which lists to cancel. What they should have done is have a contingency plan on a daily basis. If we have 5 staff absent, this is what we'll do, 10 staff and so on. And I'm pretty sure that the chief executive of that trust would not have been aware that every list was put on hold. They would have simply looked at the overall theatre utilisation figures. So these are common problems that could be relatively easily solved. Next slide, please. So to finish off, if you ask a surgeon, would you like to operate more, they'll always say yes. We get very, very frustrated at the inefficiencies in the operating theatre. Full utilisation of the day often doesn't happen. It's not unusual to see the theatre being idle for a couple of hours during the day because people are having lunch, because the recovery area is full, because there are no porters to take staff from theatres to recovery. And like many other consultants, I've spent time pushing patients in trolleys to try and get over that. So there are a number of efficiencies there. And we still find in many, many trusts that the theatres are largely idle on a Saturday and Sunday, despite the fact that many staff would be prepared to work at the weekend with the appropriate time or pay compensation. So to finish, I think these 4 points on the right are really what we need to be seeing in the 10-year plan going forward. We need adequate data. We really still do not have good data about what's going on in hospitals. As an example, in theatre utilisation, I've often seen people filling in at the end of the case the fields on the computer. When did the patient come into the anaesthetic room? When did they leave the anaesthetic room and go into theatre? So that data is not accurate. It's often not shared with the people that it actually affects, and it's often not actually used for meaningful change. We do need to empower staff and encourage innovation, and that, in my view, involves managers accepting a degree of risk and responsibility in order for those things to happen. I spent many years asking for the ability to do video calls instead of face-to-face clinics for certain patients after a transplant. I was told it wasn't safe to do because people could hack in. COVID came along and we all started doing it on WhatsApp. COVID finished and it all stopped. And lastly, I think we need to think about what is the true value that we're after here in healthcare. And that really is thinking about what are the patient's needs? What are the patient's needs in terms of their healthcare needs and also their experiential needs? And it seems to me that it's very, very rare at a local level to be focusing on that. I don't mean simply the friends and family tests, but a much more detailed assessment of what's needed. Thank you.
Thank you, Nizam. Fascinating. I mean, I was really struck by a comment about innovation is harder to do now than it was 20 odd years ago. And I could see some of the connections to what Sally was referring to earlier in terms of it's easier to go towards a big flagship ideas and investments in technology. But I think what we've been hearing from your kind of overview is get the basics right. It's so important to get the basics right. And I think what's connecting the previous conversation into yours is really thinking about the consumer, the patient needs and what we do, how it affects them. So really, really great. Thank you very much. And I'd just like to kind of just carry on with momentum and just get through our speakers and then come back to some other kind of questions. And I've got some few really interesting questions coming up, Nizam. But one of the things you picked up on was the courage for management to think and take risks and make decisions. So and I think we can all agree NHS and healthcare is a tough environment with many competing priorities, choices, and management dilemmas. But how do we move forward?